Can you start?
Please. Yes, please.
Yeah. Good morning, everyone. On behalf of Adley Oncology, I welcome our elite speakers, Dr. M.V. Agarwal, Dr. Deepanjan Haldar, Dr. Amit Khurana, Dr. Prashant Ganeshan, and Dr. Gaurav Prakash, whose presence will surely make the day an enlightening one as far as immunomodulator in hematology is concerned. A very warm welcome to all the participants for taking out their precious time this Sunday morning. Before proceeding further, I would like to take a minute to showcase what exactly Adley is doing currently and our future plans. Adley in last few years has emerged as one of the largest R&D driven manufacturing and marketing company. Currently, we are operating with 4 plants, which include a API plant as well. We have 50 plus registrations in over 16 countries and in India, we do have a sizable presence in corporate and government institutions. Our portfolio is very comprehensive and has wide range of products in solid tumor, hematology, and in supportive care. Currently, we are marketing 58 brands in India. After successful launch of blockbuster brand Bidan, the first Indian brand of dasatinib with own Indian API, we are now ready to launch the next TKI, that is exitinib, in next 2 days. I am proud that in next 6 years, we'll be launching 19 new, out of which 8 will be there in hematology, among which few will be NDDS and few will be first to launch in India. Without taking much of your time, I would like to invite Dr. M.V. Agarwal to further take up the proceedings. There is no one present here who doesn't know Sir and his contribution to medical fraternity. His name is synonymous to best academician, top clinician, and a great humanitarian. I welcome to all the speakers, and I hand over the session to Dr. M.V. Agarwal, sir, please. Thank you.
Can you see my slide?
Yes, sir.
So good morning to everybody. I'm Dr. M.V. Agarwal. Thank you very much for coming on every Sunday and joining us for these academic activities. Today, the webinar is on Lenalidomide, and as I have put it, it's a versatile immunomodulator. This activity is brought to you by Mumbai Hematology Group, supported by Adley and Mr. Ashutosh. I'm grateful to you. And as usual, Mice Ideas manage the show. Mr. Ashutosh just showed you these various brands that they have. And I'm happy to see that Lenalidomide is over here. Hardly not. And next weekend, we're going to have acute lymphoblastic leukemia, in which the PH chromosome positivity, and he has got drugs like various drugs over here. Imatinib is here, dasatinib is here. So these webinars are very relevant to Adley. And that's Lenalidomide of Adley. So Ashutosh, thank you very much. Thanks to Mice Ideas, Rajesh, Yash, Kalpesh, and the team. Thanks to the Executive Committee of Mumbai Hematology Group, faculty of today's live webinar, and all the participants. And I understand that till this morning, 525 have been the numbers who have registered, and gradually all of you will be logging in. As usual, we are going to have question and answer session at the end, so keep putting your questions in the right upper box throughout, right from the beginning. Feedback form for you to fill up to give us the idea of how you like this particular webinar, and you will get your certificates once you fill this form. Teachers today include Dr. Deepanjan Haldar, Dr. Amit Khurana, Dr. Gaurav Prakash, Dr. Prashant Ganeshan, and myself. Let me give you a flavor of what is in the stock. This evening, today evening at 6:30, we've got Ilyas Jabba, the pioneer of TKIs in the world. An evening with Professor Ilyas Jabbar discussing all about chronic myeloid leukemia beginning at 6:30 p.m. That's today. So this is a double dose to you of academics on this Sunday. Next weekend, we have got 3 of them lined up, Friday, Saturday, and Sunday. Friday, Saturday in the evening, Sunday in the morning. And this is the one Friday once again. This is chronic myeloid leukemia with none other than George Cortis. Very difficult man to get, but he's going to speak to us on futuristic views of chronic myeloid leukemia. This begins at 7 o'clock in the evening, and then next day we have Dr. Nitin Jain, the pioneer of oral treatment of chronic lymphocytic leukemia. Ibrutinib venetoclax is his protocol. He's from MD Anderson, and he's going to join us a bit early in the day, 5:30 p.m. on Saturday. And then our usual Sunday pre-lunch webinar, and this is acute lymphoblastic leukemia, and that will be as usual at 11:30 a.m. on Sunday. So CML, CLL, and ALL, three major diseases to be covered, their advances during next weekend. Most of you must have already received the emails regarding all these three, and many of you are already registered. The rest can do today. For all difficulties, contact Kalpesh at miceideas.in. Well, thank you so much. I hand over the screen to Dr. Deepanjan Haldar, who is our first speaker. It's my pleasure to introduce Dr. Deepanjan Haldar. He's consultant hematologist, hemato-oncologist, and bone marrow transplanter at a very prestigious hospital, Mumbai, Jupiter Hospital, which is situated in Thane. And he is going to speak to us about very, very basics of lenalidomide, how it works as an immunomodulator. So over to Deepanjan.
Thank you, sir. Just going to the first slide. Am I audible?
Yes.
Just going to the first slide. So I'll be talking about the basic mechanism of action of lenalidomide. I'll be covering my talk under the following headings. First, a brief introduction, then mechanism of immunomodulation. In that, I'll be covering about how lenalidomide acts by immunomodulating at different levels, that is altering cytokine production, T cell activation, augmentation of NK cell function. Then I'll be just briefly touching upon the other mechanism of action, that is anti-angiogenic activity, direct anti-tumor activity, its specific action of lenalidomide on multiple myeloma microenvironment, as well as selective efficacy in cells with deletion chromosome 5q. I'll be touching upon briefly because there are separate talks dedicated to this. So first, a brief introduction. Thalidomide actually was synthesized in Germany in 1954 from glutamic acid, and it was initially thought to be used as sedative and hypnotic antiemetic drug indicated to treat morning sickness in first trimester of gestation. But it got banned soon after, just 6 years after it was first synthesized, because of this kind of limb defects in the children noted. What is lenalidomide? Lenalidomide is second generation drug of thalidomide. It's structurally quite similar, but it's 50 to 2000 fold more potent. And as we all know, its use in hematology is quite versatile, ranging from myelodysplasia, multiple myeloma, chronic lymphocytic leukemia, non-Hodgkin's lymphoma, amyloidosis, myelofibrosis, as well as Waldenstrom's macroglobulinemia. So just a table to show the structural similarities between thalidomide, lenalidomide, and pomalidomide. There are certain minor structural differences as well. For example, thalidomide has got 2 oxo groups, while lenalidomide has got amino group and single oxo group, and pomalidomide has got amino group at 4th position and 2 oxo groups in the thalal region. Coming to the difference in immunomodulatory action, thalidomide stimulates T cell proliferation and increases interferon gamma and IL-2 production. Lenalidomide has been shown to be 100 to 1000 times more potent in stimulating T cell proliferation and interferon gamma and IL-2 production than thalidomide. Pomalidomide is similar to thalidomide. In addition, it also has got an additional mechanism of action, that is, it enhances transcription factor T-beta, which reverses TH2 cells into TH1-like cells. Coming to adverse effects, thalidomide has got higher incidence of adverse effects, for example, sedation, neuropathy, and constipation, which is likely lower with lenalidomide as well as pomalidomide. Coming to teratogenicity, thalidomide, as we all know, is a non-teratogen. Lenalidomide has not been tested in humans, but in animals it is found to be not teratogenic in rabbit models. On the other hand, pomalidomide also is a non-teratogen. Now, what is an immunomodulator? An immunomodulator is anything basically that helps to regulate the immune system. The immunomodulators appear to have both anti-cancer as well as anti-inflammatory activities. Coming to mechanism of action of immunomodulation, so lenalidomide, as we will see in the subsequent slides, it has got a versatile immunomodulation action. So basically, it acts at cytokine level by decreasing the pro-inflammatory cytokines, as well as it leads to T cell co-stimulations, increasing the Th1 cytokines, that is interferon gamma and IL-2, which further leads to T cell clonal proliferation, as well as acts at the NK cell level, thereby generating cytotoxicity against the tumor cells. In addition, lenalidomide also acts directly at the genetic level by increasing the expression of P21, which is a known tumor suppression gene. It also leads to direct G0, G1 cell cycle arrest. It has got anti-angiogenic activity by decreasing the level of VEGF and IL-6. At multiple myeloma tumor cell level, microenvironment level, it increases the level of expression of various cell adhesion molecules, and thereby it decreases the interaction between the plasma cells as well as the bone marrow stromal cells. It has got direct active action on the osteoclast level as well. It decreases the formation as well as activation of osteoclasts, and decreases the survival factors which are important for survival of osteoclasts as well. So all this we'll be seeing in detail subsequently. Now coming to the first mechanism of action, that is altering cytokine production. So it inhibits the production of pro-inflammatory cytokines, that is TNF-alpha, IL-1, IL-6, etc., and elevates the production of anti-inflammatory cytokine IL-10. Why is it important? It is important because we know that TNF-alpha is directly involved in pathogenesis of various hematological malignancies by causing stem cell apoptosis and ineffective hematopoiesis, as seen in MDS. So thereby, by inhibiting TNF-alpha, lenalidomide decreases this kind of carcinogenesis. What about IL-6? So lenalidomide decreases the production of IL-6, and IL-6 we know inhibits the apoptosis of malignant myeloma cells and helps in their proliferation. So thereby inhibiting IL-6, it can lead to its action in multiple myeloma cells. Coming to the second mechanism of action, that is T cell activation. We know that the process of T cell activation, it occurs by two steps. The first steps involve the presentation of peptide fragments by the antigen presenting cell to the T cell receptors. But this is not sufficient to activate the T cell. We need a second interaction between the B7 molecule and the antigen presenting cells. I'll be showing this subsequently in figures. And CD28 on T cell surface. So this basically functions as the co-stimulatory signal for stimulating the T cell response. So lenalidomide mainly acts as this level. So what happens is lenalidomide acts on T cells by the B7 CD28 co-stimulatory pathway. There is blockade of this interaction using the CTLA4 immunoglobulin B7 blocking antibody. This is partially overcome by IMiDs. How this is overcome? So lenalidomide directly acts on the downstream pathway, leading to tyrosine phosphorylation of CD28 on T cells, leading to the activation of downstream signals. I'll be showing this in figure when it will become more clear. So lenalidomide directly acts on downstream of CD28, leading to its phosphorylation and activation of the downstream signals. So this might explain how it is able to overcome the blockade of the CTLA4 immunoglobulin blockade. So thus, T cell co-stimulation by lenalidomide acts to an increased Th1 type cytokine response, resulting in increased secretion of interferon gamma and IL-2, that in turn stimulate clonal T cell proliferation and NK cell activity. So this is what I was saying. So these are the antigen presenting cells. This is the T cell. They are the T cell receptors. So the antigen presenting cells, through their MHC molecules, present the peptides to the T cell receptor. In addition, there is interaction between B7 present on the antigen presenting cells and CD28 present on the T cells that is responsible for co-stimulation of the downstream T cells. This leads to generation of interleukin 2 and T cell clonal proliferation. Now what happens in tumors is there is CTLA4 immunoglobulin antibody which goes and blocks these kinds of B7 CD28 interaction. Lenalidomide overcomes blockade of this interaction by directly acting at downstream of CD28, leading to its phosphorylation activation of the NF, kappa beta, and various other pathways. Now this overcomes this kind of CTLA4 immunoglobulin blockade, and this thereby leads to T cell clonal proliferation. So thereby lenalidomide directly leads to T cell activation. What about NK cell function? So modulation of NK cell function is also believed to be contributory of the anti-tumor effect of lenalidomide. The increase in NK cell function could be related to increased IL-2 production by the T cells. So the the activation of T cell leads to increased IL-2 production, which in turn activates the NK cells as well. Also, enhanced Fc gamma receptor signaling may also increase the potential of NK cells. So thereby lenalidomide activates the NK cells by two ways. Number one, it increases the IL-2 production by T cells, which leads to activation of NK cells. Number two, it activates the Fc gamma receptor signaling, which again leads to increased potential of the NK cells. So again, this is shown here. So lenalidomide acts at T cell level, increases the Th1 cytokines. So this leads to T cell clonal proliferation, as well as it activates the NK cell function, and thereby it generates the cytotoxicity against the tumor cells. So this was about the direct immunomodulatory mechanism of action. I'll be briefly covering about the other mechanisms as well. So for example, anti-angiogenic activity, direct anti-tumor activity, and briefly about how it acts on multiple myeloma microenvironment and selectively against the deletion chromosome 5q cells. So what about anti-angiogenic activity? We know that lenalidomide decreases the expression of angiogenic factors, for example, VEGF and IL-6 in multiple myeloma, thereby reducing angiogenic cells. So this has been proven beyond doubt in deletion 5q MDS patients as well, wherein in the patients treated with lenalidomide, when repeat bone marrow biopsy was done, decreased bone marrow vascularity has been noted subsequent to lenalidomide therapy. So this is one mechanism of action of decreasing the angiogenic activity. There is also another mechanism of action, that is, apart from decreasing the levels of VEGF, analysis of signal transition events show that lenalidomide partially inhibits the AKT phosphorylation after VEGF stimulation in endothelial cells. So it acts at VEGF at two levels. Number one, it decreases the vascular endothelial growth factor levels, and as well as it inhibits its activity by inhibiting the AKT phosphorylation. What about direct anti-tumor activity? So lenalidomide acts directly on tumors at cell cycle level through different mechanisms. For example, it upregulates cyclin-dependent kinase inhibitor P21, which is, we know, a key cell cycle regulator that modulates the activity of various cyclin-dependent kinases. This also, it has been shown to inhibit proliferation by causing dose-dependent cell cycle arrest at G0, G1 phase. So it acts at different cyclin-dependent kinases level, as well as it directly causes cell cycle arrest. Also, it has been shown to induce apoptosis in the multiple myeloma cell lines. Now, this was about cancer cells, but interestingly, it has been shown that lenalidomide has shown opposite effects on the growth of normal progenitors. So, on the one hand, it inhibits the cancer cell growth. On the other hand, it stimulates the growth of normal progenitors, stimulating normal hematopoiesis. What about effect on multiple myeloma microenvironment directly? So at multiple myeloma microenvironment level, the most important action is through inhibition of osteoclast activity. So we know that in multiple myeloma, osteoclast has got a central role in pathogenesis. So how does lenalidomide inhibits the osteoclast? So it directly decreases the formation of trap positive cells which form the osteoclast. So thereby it decreases the formation of osteoclast. It also decreases the level of various integrins, which are adhesion molecules needed for osteoclast activation. So it is inhibiting the formation of osteoclast as well as inhibiting its activation. It also downregulates cathepsin K, which is a major cysteine protease expressed in osteoclast, which is important for its matrix degradation in the resorption process. So thereby it acts on osteoclast through a number of different mechanisms. In addition, lenalidomide decreases the number of cell adhesion molecules, for example, ICAM1, BCAM, and E-selectin, and thereby inhibits the adhesion of multiple myeloma cells to bone marrow stromal cells. Thus, lenalidomide interferes with synergism among the osteoclast, multiple myeloma cells, and bone marrow stromal cells, and decreases osteoclastogenesis by acting at various levels. So again, this is shown here. So this part I have already discussed. This is how the lenalidomide acts at cell cycle level by increasing the expression of tumor suppressor gene P21, as well as directly causing G0, G1 cell cycle arrest, decreases angiogenesis by decreasing VEGF as well as decreasing IL-6, acts on multiple myeloma through multiple mechanisms. that is to decreasing cell adhesion molecules, which thereby lead to decreased interaction between the multiple myeloma cells and bone marrow stromal cells. It acts on osteoclasts by decreasing formation as well as decreasing activation of osteoclast level, as well as it directly decreases osteoclastogenesis and various survival factors which are important for survival of the osteoclast. So I've covered at multiple levels how lenalidomide is important as a versatile immunomodulator and its various other mechanisms as well. Again, showing here the various tumoricidal effects of lenalidomide, downregulation of cytokines, downregulation of adhesion molecules, T-cell co-stimulation, presence of tumor antigen presentation, and direct action on NK cells as well as T cells. Just briefly about action directly on the deletion 5q cells. So on 5q deletion cells, lenalidomide has got clonal dependent mechanisms. That is, it directly acts on enzymatic targets of lenalidomide within the CDR region that has got dual specificity phosphatase, that is C25C and TP2A-C alpha. So how are these phosphatases important? These phosphatases are important in cell cycle checkpoint regulation, that is a G2M checkpoint, and their inhibition by lenalidomide leads to G2 arrest and apoptosis. So thereby it directly inhibits the common these two kind of phosphatases which are important in regulating cell cycle at G2M checkpoint. And it has got clonal independent mechanisms as well. That is, it upregulates the formation of normal hematopoiesis and through immunomodulated mechanisms as well. So this is shown in this diagram. So lenalidomide, it directly acts on these two phosphatases, which are important in G2M checkpoint regulation. So this leads to G2 arrest and apoptosis, as well as restoration of effective erythropoiesis. And it has got clonal independent mechanism of action as well. That is, it upregulates various genes which are involved in erythropoiesis. It improves the hematopoiesis supporting capacity of the bone marrow stroma. So this leads to restoration of effective erythropoiesis. And as already discussed, to immunomodulatory effect, that is to increase in anti-inflammatory cytokines and decrease in pro-inflammatory cytokine, as well as anti-angiogenic activity. This leads to the arrest, G2 arrest and apoptosis of cancer cells, as well as restoration of effective erythropoiesis. So I think with that, I would like to conclude and over to Dr. Agarwal, sir.
Thank you, Deepanjan. You really made a very difficult topic very simple, and I think that has set the ball rolling for the clinical aspects of this webinar, in which you will now see the applications of this drug in various diseases. To begin with, I am going to tell you about use of lenalidomide in myelodysplastic syndrome. So I'll just share my screen. Okay, you can see my screen, please.
Yes, sir.
Okay.
Yes, sir.
So lenalidomide in myelodysplastic syndrome. First, we will talk about lenalidomide-based monotherapy. That means when you are using len alone as a single agent for the treatment of MDS. We begin with the case. Mrs. Siguera, 78-year-old from Goa. For almost about a year, she's got a refractory anemia where the MCV was high. She was transfusion dependent. Her platelet count was over 800,000. She had a very diagnostic megakaryocyte in the bone marrow. That is, the megakaryocyte was hypolobated and the nucleus was eccentrically placed. There were hardly any blasts in the bone marrow. That's her marrow, megakaryocyte, hypolobated, and nucleus eccentrically placed. These are 4 pictures of other patients from literature and my patients showing you eccentrically placed nucleus which is hypolobated. In this kind of patient, the next important test is to do karyotyping. And when you do karyotyping, you see that the 5th chromosome the long arm is deleted. So that is 5q minus, or del 5q. So we are talking about 5q deletion syndrome. Sensitivity of picking up this abnormality by FISH is higher. So if you are clinically suspicious and karyotyping does not pick it up, you should do the FISH test. And this is a FISH test of Our Lady. And to compare it with normal, you can see 2 green and 2 red dots, while our patient has got only 1 red dot. Using a specific probe, this becomes equivalent to deletion 5q. When you have deletion 5q syndrome, approximately 1.5 million base pairs of DNA are deleted. And this contains almost 40 genes. And that's the site. 5th chromosome, long arm, and that's the site. This leads to loss of RPS14, and that's the one gene which is relevant to our discussion today. Those of you who are pediatric hematologists will remember that in Diamond-Blackfan syndrome, the congenital pure red cell aplasia, exactly the same gene is faulty. So once again, the karyotyping showing you the 5th chromosome long arm being deleted, and that shows you that in this long arm, at this particular site, 3.1, 3.2, these are the various genes which get deleted. The clinical profile, to recapitulate, of 5q minus syndrome is elderly people, female more common than male. MCV crosses 100. There is thrombocytosis. Marrow resembles pure red cell aplasia. The characteristic megakaryocytes which we showed you, there is low risk of progression to leukemia. This has relatively better prognosis, and there is a targeted therapy. Before I come to the targeted therapy, I'm going to put some MCQs to you. And I'm going to ask Kalpesh to start my MCQs. Okay, so the first MCQ, which should be relatively very simple for you to answer now. MDS with deletion 5q is characterized by all except one of the following. That means 4 statements are correct, 1 is wrong. This disease has female preponderance, macrocytic anemia, thrombocytopenia, hypolobated megakaryocytes, and low risk of progression to acute leukemia. So you have to pick up a wrong statement. Your time starts now. See your voting. So, thrombocytopenia is not a common feature of this particular entity. 2/3 of you were listening to my presentation. As I mentioned, that sequela had thrombocytosis, and that's a characteristic finding of deletion 5q. So some of you missed it, 1/3 of you missed it, but 66% have answered correctly. Can we have the second MCQ, which will be a test of your knowledge, and then I'm going to answer it in my presentation. In what percentage of patients of deletion 5q is Lenalidomide effective? That means it will improve the hemoglobin. 20, 30, 65, 90. Your time starts now. So majority of you have answered that, about half of you rather, have answered that about 65% of cases Len is going to be effective. And about 1/3 of you have answered that it is effective in 90% of patients. We will see who is correct. Can we have the third MCQ? So continuing from the same disease, in deletion 5q treated with Len, you can have a complete normalization of your karyotype. That means the 5th chromosome may just appear normal. That happens in what percentage of patients? Less than 10, 35, 75, or more than 90. And your time starts now. Can you hear me?
Yes, sir.
Okay. So that's the voting poll, and we see that highest has gone to option 3. So your response is that about 75% of patients will become normal in karyotyping. I should say that majority of you have answered. Actually, it's a split house. This option is by 1/3 of you. Very close to that is 35%. That's the other answer. So whether 33% is correct or the other one is correct, we will see in my presentation. So the next MCQ, fourth one, despite deletion 5q, if lenalidomide fails, then you should suspect that your patient has got an additional abnormality. And which is that additional abnormality? And the option is trisomy 8, deletion 20q, RUNX 1, or TP53, and your time starts now. See your voting pattern now. So half of you, that is 57%, have voted for TP53, 20% have voted for trisomy 8. Now we come to the last MCQ, the 5th one. In what percentage of patients is lenalidomide effective in low risk MDS, even if there is no deletion 5q? 7%, 27%, 57%, or 77%? Your time starts now. For the last time, we'll see your voting pattern. Not having 5q minus, still then working in what percentage of patients? So the answer given by majority of you is B, that is 27% of patients. Half of you have voted for that, 53%. The rest, of course, have been split. And once again, we will see during my talk who is right. Okay, so that was the last MCQ. I'll once again share my screen. So this is where we were. So Len is a targeted therapy. I'm sure you can see my slide, right?
Yes, sir.
Okay. So Len is a targeted therapy for MDS. In fact, that's the only drug that we have as a targeted therapy for MDS. IQ minus is a genetic signature predicting response to Len. So if you have IQ minus, your treatment is Len. And who did this research? Alan List. 2006, 14 years ago, he showed that the targeted anemia therapy for MDS is Lenalidomide, published in New England Journal, 2006. Several clinical trials have been undertaken studying the efficacy of Len monotherapy, low-risk MDS with 5q-. The hematological response rates are high. 65% of patients become transfusion independent. Median duration of response is about 2.5 years. That means half of the patients will maintain this response beyond 2.5 years. In some patients, the response can last for years. Occasional patient, hemoglobin can rise even above 17 grams, needing therapeutic phlebotomy, and the dose of Len can be reduced. Almost 50% to 75% achieve cytogenetic response. 35% of them is complete cytogenetic response, and that was your answer to the second MCQ. Furthermore, Len delays progression to acute myelodysplastic leukemia, and it prolongs survival amongst responders. So you got triple advantage. Your hemoglobin improves, you become transfusion free, the chance of developing AML is delayed, and your survival is increased. 67% success means 33% failure. Is this just the luck that somebody responds and others don't? The answer is no, it's not just the luck. Dr. Ghulam Mufti from King's College, London, gave the answer by doing molecular profiling of these patients. In MDS, overall, there are 40 recurrently mutated genes, and these are those genes which have been classified into 5 groups: the tyrosine kinase pathway, the transcription factor, the epigenetic dysregulation, and the splicing factor genes, and then there is a miscellaneous group. In this miscellaneous group, there is one important gene, that is TP53, and that is important to our discussion today, TP53. So what Dr. Ghulam Mufti showed, that if you have deletion 5q alone, then 2 out of 3 patients will respond to Len. But if this is associated with TP53 mutation, then you fail to respond to Len. Similarly, if you have got complex cytogenetics, then also you fail to respond to Len. So there are 2 markers which tell you when you will not respond. This is his publication, 2011, TP53 mutation, low-risk MDS with deletion 5q predict disease progression. Lesson learned is that if you have a female patient who is elderly with refractory anemia and macrocytosis, do karyotyping. If it's normal, do FISH, look for deletion 5q, do NGS for TP53 mutation. If TP53 mutation is not there and FISH or karyotyping show you deletion 5q, Len will be invariably successful. Complex cytogenetic abnormalities or TP53 mutation means there will be failure. Coming to whether Len works without deletion 5q. So what an MDS patient with anemia, there is no deletion 5q even by FISH. The answer is yes, and that was your third MCQ, and majority of you answered correctly, 27%. So 27%, that is 1 out of 4, will respond to Len without 5q minus. And let's have a case study to confirm this. Narayan, K, 73-year-old from Kochi, seen first in 2017, had a low-grade MDS with hemoglobin very low. He was transfusion independent for a year. There was no deletion 5q. His EPO level was pretty high. He was needing 4 bags of transfusion every month. He was offered Len as a trial and he accepted. He became transfusion free and he's transfusion free for last 18 months and his last hemoglobin is over 10 grams. Why does this happen? So the Italian MDS expert Valeria Santoni has the answer. This is her publication 4 years ago, 2016. Randomized phase 3 study of Len versus placebo in transfusion-dependent patients with low-risk non-deletion 5q MDS. What she showed was that about 26.9% of patients of this particular category will respond to Len and become transfusion-free. Why does this happen? Can you predict this? Yes, there is a predictability. If you do NGS, and if you find trisomy 8 or deletion 20q or RUNX1 mutation, the chance of your responding to Len is quite good. But if you find mutation in SFTB1, TAT2, WNT3A amplification or MCL1 amplification, your chance of responding to Len is poor. So upfront, a patient can be told by NGS study what his chances are of responding to Len. Lesson learned, in low-risk MDS, without deletion 5q, it is worth trying Len for 2 months, and NGS study are good predictor. We come to combination therapy. So Len-based combo. Combination therapy with Len has various examples. 4 of them I want to discuss today. Len with erythropoietic stimulating agent, Len with immunosuppressive therapy like ATG, cyclosporine, steroids, Len with thrombopoietin receptor analogs like atrembopag and romiplastim, and Len with hypomethylating agents like azacitidine and dasatabine. Let's see the case again. This is Mr. Patil, 73, Kolhapur, seen in 2017. For symptomatic anemia of half a year, he was incapacitated and wanted some help. A lot of comorbidities here, IHD, COPD, DM. Hemoglobin was pretty bad, below 7 grams, and he has received 18 units of transfusions in last 6 months. Workup showed MDS RA. There was no 5q deletion, and his EPO level was also high, 580. He was not a perfect case for Len, not a perfect case for erythropoietin stimulating agents, and not a perfect case for ATG. Erythropoietin stimulating agents like erythropoietin or darbepoietin best work when the EPO levels are below 100. And if it is above 500, we almost never try. Also, it works if there is a low transfusion requirement and our patient had high transfusion requirement. ATG works usually in female patients, younger patients who have hypoplastic MDS, low transfusion requirement, trisomy 8, small PNH clone, HLA-DR15, and absence of ring sideroblasts and absence of SF3B1 mutation. So we gave our patient Darbe 500 micrograms subcutaneously once every 3 weeks. He didn't respond. Len was added 10 milligram per day for 3 weeks on and 1 week off. And a magic happened. In 2 months, he became asymptomatic, free from transfusion, enjoying outdoor activities, socializing, and started going to club as well. He's now with us for last 2 years. His hemoglobin is nearly normal, and we have reduced his frequency of Darbe to once a month. So lesson learned is Len plus ESA combo works. This works in low-risk MDS where ESA has failed. So before you call it a day, add Len for 2 months and see 20% of patients will respond. The median duration of this response could be almost 1.5 years. These are studies showing you combination of Len and EPO, published by Komroxy and by Toma, phase 2 and phase 3 study, variable number of patients, 39, 131, and the responses. Len in combination with immunosuppressants. So several trials have investigated combination of Len with either ATG or cyclosporine or steroids in low-risk MDS, not having deletion 5q. Most of this work has been done for hypoplastic MDS. The next one is Len with thrombopoietin receptor analogs. So those patients who have associated severe thrombocytopenia, Len has been combined with Romi or Eltrumbo. Romiplastin was associated with increased risk of conversion to acute myelodysplastic leukemia in comparison to the placebo group, and therefore those trials were discontinued. These are now studies to show you Len combined with immunosuppressive agents like cyclosporine, prednisolone, and Len combined with TPO-RA, Romiplastin, Eltrumbopag, and some other studies. Len in combination with hypomethylating agents. So most of the work is with azacitidine. So there is a potentially synergistic effect of patients who have MDS or probably even in patients of AML. Various details are over here, which I'm not going to go through, but in patients of high-risk MDS, usually you give azacitidine, but there's a place for aza with Len, and that is also a place for patients of elderly AML. So this is phase 2 study published in 3 years ago, aza alone versus aza with Len, or even aza with vorinostat in high-risk MDS or CMML. This is a single study of Len with decitabine. Most of the studies are with azacitidine. So these are the giants, phase 1-2 studies, Len with aza, Len with aza, Len with aza. 36, 19, 88 patients. Remember, when you give combo, you are doubling the side effects. So be careful before trying them too much. How does Lenalidomide work in the group of patients that I have discussed? Deepanjan has told you many things. I'm just going to take your 2 minutes. So mechanism of Len is complex and incompletely understood. It has a direct effect on MDS cell, where it interferes with its proliferation and causes its death. And it also modulates the microenvironment, acting as an immunomodulator. So this is a cartoon of EM picture where Len has been directly acting on MDS cell. Len is effective by directly acting on various cancer cells, myeloma, MDS, and mature cell non-Hodgkin lymphoma. And this activity, this effect of Len is maintained even in the absence of immune effect. And therefore it is disease-specific and cell-intrinsic effect. It appears that the cerebron-mediated degradation of CK1 alpha and Icarus is important mechanism to explain Len-mediated apoptosis in 5q minus MDS. As an immunomodulatory, it works at multiple levels, so beautifully discussed by Dr. Haldar. It acts on the cellular, that is T cell and NK cell, and also on the humoral, on the cytokines. In 5q minus, it is thought to work by immunomodulation through activation of T cell response by activating CD28. So there is a predictor. CD28 expression could predict the response to Len. Len is an anti-inflammatory. In MDS, there is enough documentation that the microenvironment is inflammatory. And that's detrimental to hematopoiesis, leading to cell death, and then cytopenia. Len decreases the production of pro-inflammatory cytokine like TNF-alpha, IL-6, IL-1, IL-12, and increases anti-inflammatory cytokines like IL-10. For this activity, Len is 50,000 more potent than thalidomide as far as the down-regulation of TNF-alpha is concerned. Len is anti-angiogenic. In MDS, bone marrow niche is characterized by increased neoangiogenesis, and there's overexpression of VEGF receptor. Len, by its anti-angiogenic effect, reduces this vascularity and in turn leads to decrease in the rate of disease progression. And this cartoon tells you various activities of Len through cerebrone, immunomodulator, effect on the microenvironment, anti-angiogenic, and anti-proliferative. This cartoon was shown by Dr. Haldar. So you've got a clonal dependent mechanism of action and clonal independent mechanism of action. And same thing over here, MDS 5q minus haplodeficient cell directly is damaged by Len, and there's an indirect immunomodulatory action through T cells. So the good news is that Len is useful to patients of MDS, and plenty of patients, the quality of life can be made wonderful. Thinking about the future research is needed to discover the biomarkers and further improve our ability. I tried my best to show you how you can predict the response, but we need more biomarkers to improve our ability to select patients who will respond to Len, as well as design an optimal Len-based combination. You must have seen that all those 4 combinations were a little bit in preliminary stage. So Len-based combination which will give maximum synergistic activity with minimum of toxicity. Well, thank you very much for giving this opportunity. I will stop sharing my screen. And it's my pleasure now to invite my friend, Dr. Amit Khurana from Surat. He's hematologist, hemato-oncologist, and bone marrow transplanter. And he's going to tell us all about Len in myeloma. Over to Amit Khurana.
Thank you so much, sir, for giving me this opportunity. I will share my screen now. Can you see my slides?
Yes, sir.
Okay. So we'll discuss about Len in multiple myeloma. Starting with the structure, it differs from the parent atom, that is lenalidomide, in the number of nitrogen atoms. That is 3 nitrogen atoms in Len as compared to 2 in Thel, and 3 oxygen atoms in Len as compared to 4 in Thel. Coming to the mechanism of action, I will not go in detail as Dr. Deepanjan as well as Dr. Agarwal sir has mentioned very in detail, but I will just brief about the headings of mechanism of action. The most common being immunomodulation, which is due to altered cytokine production, T cell co-stimulation, as well as NK cell cytotoxicity. It downregulates the pro-inflammatory cytokines, namely TNF-alpha, IL-1, IL-6, and IL-12, and upregulates the anti-inflammatory cytokines, namely IL-10. TNF-alpha is downregulated about 5,000 times more as compared to thalidomide, with maximum inhibition of IL-6. It has got profound T cell activation, profound NK cell activation, which results into antibody-dependent cell-mediated cytotoxicity. It has got profound anti-angiogenesis activity, which is about 2 to 3 times more potent than thalidomide, due to marked decrease in VEGF and IL-6 levels. It has got direct anti-tumor activity as well as affects the myeloma microenvironment. So multiple mechanisms starting from anti-angiogenesis, inhibition of bone marrow stromal cell interaction, decrease in osteoclastogenesis, decrease in pro-inflammatory cytokines, augmentation of NK cells, T cell co-stimulation, increase in tumor suppression gene, and cell cycle arrest. So let's start with Len in newly diagnosed multiple myeloma. Excellent article in 2010, Len with high-dose dexa compared with only dexamethasone as initial therapy for multiple myeloma. It clearly showed PFS benefit with Lendex as compared to dexamethasone. But there was no oral survival benefit with Lendex as compared to dexamethasone. Again, oral survival benefit was seen with Lendex in the patients without cytogenetic abnormalities as compared to patients with cytogenetic abnormalities. Benefit was seen again in deletion 13q and translocation 414 with no reduction in overall survival, but there was decreased overall survival benefit with deletion 17p13. Excellent response rates were seen with Lendex as compared to only dexamethasone in terms of overall response rate as well as complete response rates. Yet another article in 2010, Len plus high-dose DEXA versus Len plus low-dose DEXA as initial therapy for newly diagnosed multiple myeloma. The low-dose DEXA dose was 40 mg given on day 1, 8, 15, and 22, and high-dose DEXA dose was 40 mg given on day 1 to 4, 9 to 12, and 17 to 20 every 28-day cycle. Overall survival benefit was excellently seen with Len with low-dose DEXA as compared to high-dose DEXA. Again, PFS benefit was seen with Len with low-dose DEXA as compared to high-dose DEXA. Overall survival benefit at extended follow-up was again seen with Len with low-dose DEXA as compared to high-dose DEXA. Again, overall survival benefit was also seen in older age group with Len with low-dose DEXA who are more than 65 years of age at 1 year follow-up. Again, overall survival benefit was seen with Len with low-dose DEXA as compared to high-dose DEXA in patients who were transplanted versus patients who were not transplanted. Again, excellent response rate was seen with Len with low-dose DEXA in terms of PR rates, CR rates, as well as VGPR rates as compared to high-dose DEXA. Grade 3-4 adverse events were lower with Len with low-dose DEXA as compared to high-dose DEXA in terms of hematological toxicity as well as non-hematological toxicities. Yet another article in 2010, Lendex versus Theldex in newly diagnosed multiple myeloma, an analysis of 411 patients clearly showed benefit with Lendex as compared to Theldex in terms of PR rates, VGPR rates, and CR rates. Out of 411 patients, 144 patients received high-dose dexamethasone. Again, excellent benefit was seen in PR, VGPR, and CR rates with Lendex as compared to Theldex. Excellent overall survival benefit was seen with Lendex as compared to Theldex in terms of time to disease progression, PFS benefit, overall survival benefit in patients undergoing stem cell transplant, as well as overall survival benefit in patients not undergoing stem cell transplant. This you can see in this figure also. Increased time to disease progression with Lendex as compared to Theldex. Increased PFS survival with Lendex as compared to Theldex. OS benefit with Lendex as compared to Theldex. OS benefit with stem cell transplant with Lendex as compared to Theldex. Again, OS benefit without stem cell transplant with Lendex as compared to Theldex. The adverse events in both the arms were almost comparable, but with a higher incidence of neutropenia in Lendex arm as compared to Theldex arm, and a higher incidence of neuropathy and grade 3 for peripheral neuropathy in Theldex arm as compared to Lendex arm. All other adverse events were almost comparable, but there was high incidence of diarrhea in Lendex arm as compared to high incidence of constipation in Theldex arm. So to summarize, Len with low-dose DEXA in newly diagnosed multiple myeloma improves the progression-free survival, increases the time to progression, advantage in deletion 13q and translocation 414, improves the response rates, improves the overall survival, OS benefit in both transplant-eligible and non-eligible patients with fewer toxicity, and hence it's a standard of care for newly diagnosed multiple myeloma. Next, let us go for Len in relapsed refractory multiple myeloma. Excellent article from NEJM 2007, Len plus DEXA for relapsed refractory multiple myeloma in North America by Donna Weber et al. It clearly showed Len increased the time to disease progression as compared to placebo. Again, increased time to disease progression was seen with Len without previous lenalidomide exposures. OS benefit was seen with Len as compared to placebo. Again, OS benefit was seen with Len with or without previous lenalidomide exposure. Yet another article from NEJM 2007, Len plus DEXA for relapsed refractory multiple myeloma by Melitius et al. Clearly showed again Len increased the time to disease progression as compared to placebo. Increased time to disease progression again with Len without previous lenalidomide exposure. OS benefit with Len as compared to placebo. OS benefit with Len with or without previous lenalidomide exposure. Excellent response rates were seen with Lendex as compared to only placebo in terms of PR rates, CR rates, overall response rate with no prior lenalidomide exposure, 1 or 2 prior therapy, IgA disease or without IgA disease, irrespective of age group, whether less than 65, 65 to 75, or more than 75 years old. Irrespective of creatine clearance, whether less than 30, 30 to 50, less than 80, or more than 80. Excellent response rates were seen in all the groups with Lendex as compared to only DEXA. Yet another article in 2009, Len in combination with DEXA at first relapse in comparison which is used as later salvage therapy in relapsed refractory multiple myeloma, clearly showed PFS benefit with Len with 1 prior therapy as against to 2 prior therapies. Again, time to disease progression was benefited with 1 prior therapy with Lendex as compared to 2 prior therapies. OS benefit excellent with Lendex with 1 prior therapy as compared to 2 prior therapies. So to summarize, Len in relapsed refractory multiple myeloma increase the time to disease progression, OS benefit, excellent response rate in all the groups, irrespective of previous lines of therapy, and best response if used early in patients refractory to first prior line of therapy. Next, let us discuss about Len in maintenance therapy for multiple myeloma. 2012 beautiful article from NEJM, Len maintenance after stem cell transplant for multiple myeloma based on IFM 2005 trial. It was a randomized controlled trial, double-blinded, placebo-controlled phase 3 study from 2006 to 2008, where every patient after induction chemotherapy was given Len consolidation for 2 cycles, and then 1:1 randomization between Len maintenance versus placebo. The dose in Len maintenance was 10 milligram per day for first 3 months, followed by 15 milligram after 3 months. The primary endpoint being progression-free survival, and secondary endpoint was RR, event-free survival, and overall survival. Excellent response rates were seen with Len maintenance as compared to placebo in terms of progression-free survival at 3 years. 3 years progression-free survival was also excellent in those patients who had VGPR versus as well as in those patients who had no VGPR, irrespective of beta-2 microglobulin levels and irrespective of 13q deletion status. But there was no overall survival benefit at 3 years with Len maintenance as compared to placebo. Again, you can see here, PFS benefit at 4 years, excellent with Len maintenance. 4-year event-free survival, excellent with Len maintenance. CR rates, VGPR rates, excellent with Len maintenance, but no OS benefit at 4 years with Len maintenance as compared to placebo. And there was higher rates of grade 3 for hematological events as well as secondary primary malignancy with Len maintenance as compared to placebo. You can see in this graph also, PFS benefit excellent with Len maintenance, but no overall survival benefit with Len maintenance. Yet another article in 2012, NEGM, Len after stem cell transplant for multiple myeloma based on CARL-GB trial, where patients from 18 to 70 years of age with symptomatic myeloma given 2 cycles of induction therapy followed by autologous stem cell transplant. And between day 100 to day 110 after autologous stem cell transplant were randomized between Len maintenance versus placebo. Excellent PFS benefit with Len maintenance versus placebo, but only a slight overall survival benefit with Len maintenance as compared to placebo. Yet another article in 2019, Len maintenance versus observation for patients with newly diagnosed multiple myeloma, Myeloma 11 trial, clearly showed PFS benefit with Len maintenance as compared to placebo, but no overall survival benefit with Len maintenance as compared to placebo. A second PFS benefit was seen with Len maintenance as compared to placebo. PFS benefit was seen in transplant eligible as well as in transplant ineligible patients. Overall survival benefit with Len maintenance was seen in transplant eligible patients, but no overall survival benefit was seen with Len maintenance in transplant ineligible patients. Again, Len maintenance improves the progression-free survival in those patients who are MRD negative as compared to those patients who are MRD positive. Coming to continuous Len therapy for myeloma. CARL-GB clearly showed PFS benefit with continuous Len therapy. CARL-GB data clearly showed OS benefit with continuous Len therapy. IFM clearly showed PFS benefit with continuous Len therapy. MM015 trial where 3 groups were randomized. The first group received MPR followed by continuous Len therapy. Second group only MPR and third group received MP. Clear-cut PFS benefit was seen with MPR followed by continuous Len therapy in newly diagnosed transplant non-eligible candidates. Again, in the first trial of 1623 patients, 3 groups were randomized. First group received continuous Lendex. Second group only Lendex for 18 months and third group received MPT. Clear-cut PFS benefit was seen with continuous Lendex in the first trial of 1623 patients. But no overall survival with continuous Lendex in this first trial of 1623 patients. Again, the duration of response deepened with continuous Lendex in the first trial of 1623 patients. So to summarize, Len as continuous maintenance therapy increases the progression-free survival in both transplant eligible and ineligible patients, increases the event-free survival, improves the response rates, overall survival benefit in transplant eligible candidates, higher rates of MRD negativity, increased duration of response, but with a higher grade 3, grade 4 hematological events and high incidence of secondary primary malignancy. Tandem autologous stem cell transplant did not seem to benefit from Len maintenance as much as single autologous stem cell transplant. And Len maintenance did not prove benefit for high-risk cytogenetics and with creatine clearance of less than 50 ml per minute. So the question arises, does consolidation obviate the need for continuous therapy? Consolidation with at least 2 cycles of 25 milligram Len provided only PFS benefit and not the overall survival benefit. Hence, continuous therapy with Len is must without consolidation. So FDA approved in 2006 Lendex for multiple myeloma previously received more than 1 prior therapy. 2015 Lendex for newly diagnosed multiple myeloma not eligible for stem cell transplant. And in 2017 FDA approved Len as maintenance treatment after stem cell transplant. Coming to Len in smoldering multiple myeloma. Excellent 2013 article from NEGM Len plus Dexa for high-risk smoldering multiple myeloma, where high-risk features were defined as plasma cell bone marrow infiltration of more than 10% with a monoclonal component, or any one of these two criteria met with more than 95% phenotypically apparent plasma cells in the bone marrow plasma cell component with reduction in 1 or 2 uninvolved immunoglobulin levels of more than 25% as compared to the normal values. So Lendex was given for 9 cycles, followed by Len maintenance until disease progression. The primary endpoint was time to progression to symptomatic disease, and secondary endpoints were RR, overall survival, and safety. Excellent results were obtained with Lendex as compared to only observation. In terms of time to disease progression, decreased incidence of symptomatic disease, OS benefit at 3 years, OS benefit at 5 years, PFS benefit at 3 years, but increased incidence of adverse events with Lendex as compared to observation. So to conclude, Len-based treatment in high-risk smoldering myeloma was associated with significant delay in the progression to symptomatic myeloma. Yet another recent article in 2019, randomized trial of Len versus observation in smoldering myeloma, where Len was compared with observation until disease progression, toxicity, and withdrawal. And all the patients of smoldering myeloma who were asymptomatic were randomized into 3 groups, low, intermediate, high risk, based on Mayo 2018 risk classification for smoldering myeloma. And the primary endpoint was progression-free survival. Excellent PFS benefit with Len as compared to observation was seen, with a reduced incidence of progressive disease with Len as compared to observation, but no overall survival benefit in smoldering myeloma with Len as compared to observation. Again, in high-risk smoldering myeloma, excellent PFS benefit was seen with Len as compared to placebo, but no much PFS benefit in intermediate risk smoldering myeloma as well as in low-risk smoldering myeloma with the use of Len. So to conclude, early Len intervention does prevent the development of organ damage and symptoms with a 72% risk reduction in more than 2 years compared with the control arm. And Mayo 2018 high-risk category favored early intervention with no negative impact on health quality of life, and toxicity was manageable. Coming up next, the toxicity and management of Len. Every elderly patients who are more than 75 years of age with comorbidities, low performance score, and low tolerance, Dexa dose should be reduced to 20 milligram. And if very frail, Dexa can be reduced to 16 milligram. Len dose reduction should be done based on dose reduction level, as first dose reduction, second, third, and fourth dose reduction, so 25, 15, 10, 5 milligram, and so on. Len should be renal dose adjusted based on creatinine clearance in patients with mild, moderate, severe, and end-stage renal disease. Coming to hematological toxicity, the most common being neutropenia. ANC count of less than 1,000, you should stop Len. Once ANC resumes to more than 1,000, in the next cycle, Len should be started with the next level dose reduction. Any platelet count of less than 30,000, Len should be withheld. And once platelet count is more than 30,000, in the next cycle, Len should be started with next dose reduction level. Anemia can be taken care of with erythropoietin limiting agents, but the point to be kept in mind that hemoglobin should not exceed 12 grams per deciliter because of high incidence of venous thromboembolism. Coming to non-hematological toxicities, there are many, starting from thromboembolic risk, which increases with dexamethasone, higher in first few months and then decreases thereafter. No thromboprophylaxis needed with Len monotherapy, and drug of choice for thromboprophylaxis is ecosprin at a dose of 81 milligram per day. But if the patient has got history of thromboembolism or non-thrombotic disorder, best to start the patient on anticoagulation. And thromboprophylaxis should be stopped once platelet count is less than 50,000. Infections are again not uncommon and they are usually low grade, but 10 to 20% patients may develop grade 3-4 infections. But antibiotic prophylaxis should be given only in high-dose dexamethasone patients. Len-induced skin rash is again not uncommon. It can be localized maculopapular rash or extensive Stevens-Johnson syndrome-like rash, which has to be taken care of with localized steroids, oral steroids, or even permanent discontinuation of Len. Teratogenicity is a big concern with Len, and both male and female patients must adopt strict birth control practice with complete abstinence and use of 2 contraceptive methods 4 weeks before starting Len and 4 weeks after stoppage of Len. Breastfeeding not recommended, sperm donation not recommended, blood donation not recommended during Len therapy as well as 1 month thereafter. Other side effects can be fatigue and muscle weakness, diarrhea, constipation, liver failure, hypothyroidism, hyperthyroidism, muscle cramps, and peripheral neuropathy, the incidence of which is less as compared to thalidomide. Other than this, patient can have insomnia, pedal edema, tremors, and not to forget, every patient on Len should be counseled for secondary primary malignancy. Every patient should be lab monitored with CBC once every 2 weeks for the first 3 cycles and then once a month thereafter. Serum creatinine should be done before each cycle of Len, and LFT and TFT should be periodically monitored. And not to forget, every woman in reproductive age group on Len therapy must have their pregnancy test done. With 2 pregnancy tests negative, within 7 to 14 days and at 24 hours before Len administration. Pregnancy test should be repeated weekly for first 4 weeks and then monthly thereafter until 4 weeks after treatment cessation. So take home message, Len test is an established backbone with a significant overall improvement in newly diagnosed myeloma, relapsed refractory myeloma as a maintenance therapy as well as in smoldering myeloma. So adding to this Lendex backbone is a present therapy of multiple myeloma. So you add proteasome inhibitor, which can be bote, carfil, or ixa, or you add monoclonal antibodies like daratumumab or inotuzumab. That makes a triplet therapy for multiple myeloma. And tomorrow is the future of multiple myeloma with Lendex at the backbone, and you add proteasome inhibitor, monoclonal antibodies. That becomes a quadruplet therapy of multiple myeloma. Thank you so much for the patient hearing.
Thank you so much, Amit. That was complete. We move on to now lymphomas. And we've got 2 talks. The first one is on follicular lymphoma from Dr. Prashant Ganeshan. Dr. Prashant Ganeshan, my friend, is additional professor and head, Department of Medical Oncology at Jawaharlal Institute of Postgraduate Education and Research at Puducherry. Last time we missed him because of the storm which made him disconnected from us. Today we are privileged that he is back with us. So over to Dr. Ganeshan.
Thank you very much, sir. It's a great pleasure. So I will be going on with my talk. I'll be talking about the role of Lenalidomide in follicular lymphoma. Follicular lymphoma, as we all know, is a slow-growing cancer, and many patients actually do not require immediate treatment. The 10-year survival is excellent. It's close to 80% is what is being reported by the recent trials of this disease. Rituximab has made a huge impact in the survival of follicular lymphoma, as has been shown by various trials where the use of rituximab has hugely improved the survival of these patients. Just to summarize the frontline therapy of follicular lymphoma, broadly it can be divided into 3 categories. The very low burden disease, that is the minority of the patients, some of whom who present with limited stage disease which can be tackled or completely cured with the use of radiation therapy without some additional rituximab-based chemotherapy. There is a subgroup of patients who have present with advanced stage, however, with low tumor burden. There are 2 options in these patients. One is to wait and watch, and the other option is to treat with rituximab alone, both of which have got excellent long-term survival outcomes at this point of time. However, the majority of follicular lymphoma patients actually present with advanced disease with significant burden of disease which necessitates immediate treatment. In these patients, the standard of care at this point of time is to use chemoimmunotherapy with either rituximab or obinutuzumab, followed by rituximab or obinutuzumab maintenance. The chemotherapy backbone itself can vary between CHOP, COP, or bendamustine. The evidence for this comes from the STILL study, which has shown that the long-term progression-free survival with the bendamustine rituximab regimen is superior to what has been achieved with CHOP rituximab. And the evidence for the rituximab maintenance is from the PRIMA trial, which has shown continued benefit at 10 years from the use of rituximab maintenance. What changes now is the publication of the data on the use of Lenaldomide with rituximab in the first-line therapy of follicular lymphoma. So what we will be discussing today is the role of Lenaldomide in the first-line therapy of follicular lymphoma, in relapsed follicular lymphoma, and the concepts and dosing of Lenaldomide in follicular lymphoma, and some discussions about the long-term data and the side effects. Coming to the Lenaldomide in first-line therapy of follicular lymphoma, one of the first trials which looked at this with the R-square regime, that is the Lenaldomide plus Revlimid regime, used a Lenaldomide dose of 20 milligrams, 21 out of 28 days for 6 cycles, along with rituximab in standard doses. And in this study, the responding patients continued up to 1 year. The complete response rates were excellent at 87% and with excellent 2-year and 5-year progression-free survival. Based on this, a small phase 2 randomized control trial was conducted by the Swiss group, and in this, they had fairly high-risk patients. Almost half of them had high-risk SLP and 41% had bulky disease. In this, they compared rituximab alone versus rituximab plus lenalidomide. they could show a definite improvement in the complete response rate with the addition of lenalidomide at 61%, and the progression-free survival is 5 years with the combination versus only 2.3 years with the use of rituximab alone. As is the general trend with all the studies in follicular lymphoma, there was no difference in the overall survival. Obviously, with the addition of lenalidomide, there was an increase in the grade 3 adverse events at 56% versus 22%. However, this was the first study to show clear evidence for an improved outcome with a chemo-free approach in follicular lymphoma. However, the landmark study, which establishes the role of lenalidomide in follicular lymphoma, so to speak, is the relevance study, which was published in 2018. In this study, previously untreated patients with advanced follicular lymphoma requiring treatment as per the GELF criteria. They were stratified based on their FLIPI score, age, and lesion size into two arms. One is lenalidomide with rituximab versus the chemotherapy of choice, that is either CHOP, CBP, or bendamustine with rituximab. In this study, again, the lenalidomide was dosed at 20 milligrams on 3 weeks out of 4 weeks, and the rituximab was given as standard doses. And after completion of 6 cycles, both arms got rituximab maintenance. Please note, the primary endpoints of this trial was CR or CRU at the end of 2 years, that is 120 weeks, and the progression-free survival. This was designed to be a superiority design with the concept that the R-square regimen would be better than the chemoimmunotherapy regimen. If you look at the baseline characteristics in this study, the median age was 59 years. Most of the patients had stage 3 or 4 disease, and close to half of them had bulky disease. And again, most of them had FLIPI intermediate or high-risk disease. Follicular lymphoma grade 1 and 2 predominated, with only about 12 to 13% having 3A disease. What was the findings of this study? Unfortunately, this study failed to meet its primary endpoint to show superiority of the R-square regimen over the R-chemo regimen. There was absolutely no difference to show actually between the R-chemo and the R-square, and the median follow-up of 37.9 months, the interim PFS was similar between both the arms. Even the other endpoint, that is the CR or CRU at 120 weeks, was 48% versus 53%, absolutely no difference. This trial has been often called as a positive-negative trial because even though statistically this has not met its primary endpoint of showing superiority, the absolute overlap of the curves has been interpreted by most investigators as an equivalence, or almost to take that R-square will do as well as R chemotherapy, and this is now being considered as one of the options of therapy in first-line therapy of follicular lymphoma. When they looked at the pre-specified subgroups of age, sex, disease stage, and the lymph nodal size as well as the FLIPI score, there was no difference. This is unfortunate because you really are not able to pick out a group which would benefit with an R-square regimen over the R-chemo regimen. So there is no help here to show which regimen you would choose in a given patient, assuming all other aspects are equal. This is a more recent update of this study. This is a sub-study of the relevance from the LISA group. Out of the total 1,030 patients who were enrolled in the relevance study, about 581 of them were France, and 440 of them were included in this minimum residual disease assessment, out of which the data of this was available in about 200 patients. Of these, 122 was in the R-square arm and 100 were in the chemo arm. How was the MRD assessed? Was assessed with a Biomed-2 detectable BCL2 JH translocation, and they used a droplet digital polymerase chain reaction, which had a sensitivity of 1 in 10,000. With that, they could show a complete molecular response at week 24 in 90% of the patients on R-square versus 77% of patients on R-chemo arm. Clearly, the CMR rates were much higher in the R-square arm, and the 3-year PFS of those who achieved CMR was 84% versus those who not in CMR was 55%. So there is something here. Maybe we need more long-term data to show whether we really need to look at a different endpoint in terms of MRD achievement in follicular lymphoma patients. This is really a provocative data just published a few weeks back. Coming to the safety in the relevant study, The adverse events are different between the R chemo and the R square, even though they were approximately same in terms of the grade 3-4 reactions. The neutropenia, febrile neutropenia, nausea, vomiting was more with R chemo, whereas the cutaneous reactions, tumor flare, and diarrhea was more with R square. Led to similar rates of discontinuation, about 30% with lenalidomide and similar rates with chemotherapy. And the rates of discontinuation due to toxicity was 8% versus 3%. The other concern with the use of lenalidomide, which has been highlighted from the myeloma studies, is the occurrence of second primary malignancies. However, in this trial, all second primary malignancies were similar, 7% with len versus 10% with chemo, and the invasive SPM was 5% for both arms. So how to choose the first-line therapy in follicular lymphoma? What are our treatment goals? PFS is a very good endpoint for follicular lymphoma, as no trial has been able to show the overall survival difference at this point of time. Should we be recalibrating and look at PET-CR or MRD negativity? Only time will tell. But there is interesting data both from the Gallium study and also from the relevant study which I just showed, that if you achieve a PET-CR, you're having better outcome, and if you're getting an MRD negativity, you are having a better outcome. Avoiding transformation was an initially stated goal. However, with the current use of chemoimmunotherapy, the risk of transformation in follicular lymphoma is actually quite low. And also the side effects, which must be a concern, both the short and the long-term side effects. So between these options, we can choose any one in a given patient. Just quickly run through the role of lenalidomide in relapsed follicular lymphoma. The first study, which used a single agent lenalidomide in this group of patients, used a dose of lenalidomide 25 milligrams, showed that there is definite activity in relapsed follicular lymphoma, the overall response rate of 26% and a median PFS of 4 months. Remember, this was a very heavily treated population with a median of 3 prior chemotherapy regimens. The randomized trial, which established the role of lenalidomide in relapsed follicular lymphoma, is called the AUGMENT study, which compared len with rituximab versus placebo and rituximab. Again, the len here was used at 20 milligrams on 3 out of 4 weeks, and clearly a median PFS advantage of 39 months versus 14 months. Infections and neutropenia rates higher with the chemotherapy, rashes higher with, so infections, neutropenia, and rash all were higher with len rituximab versus rituximab alone. So do we really need the rituximab? This is a question which was asked by this CalGB trial, it's called the Alliance trial, which is a relatively smaller trial, but this had an interesting design in relapsed follicular lymphoma comparing len versus len rituximab. Here, one arm used len alone, whereas the other arm used len plus rituximab. And they had an interesting way of dosing. They used 15 milligrams in C1 and 20 in C2 and 25 in C3, depending on the tolerance. They clearly showed with the addition of rituximab, you had an improvement in response rate of up to 76% versus 53%. So it does seem to suggest that even after failure of the first-line chemoimmunotherapy, when you want to use lenalidomide as second-line therapy, it is important to combine it with rituximab. The adverse events did not significantly increase with the addition of rituximab. What about maintenance lenalidomide in the relapse setting? Do we need to continue? This is a question which is being asked by the Magnified trial, which had 2 components. The induction component, which is same as the AUGMENT trial, that the len dosed at 20 milligrams along with rituximab for a year. However, there was a subsequent randomization to rituximab alone maintenance versus len plus rituximab maintenance, len at a dose of 10 milligrams. However, at this point of time, we do not have data of the maintenance component of this study. It's probably expected very soon. Just a word on the dosing of lenalidomide. A variety of dosing schedules has been used, but if you look at this table, you will see that both in the relapse as well as in the upfront setting, the most popular dosing regimen is 20 milligrams OD, 3 out of 4 weeks, and this is probably the dose that I would choose for most of the patients whom I am starting lenalidomide in follicular lymphoma. Just to summarize, treatment of relapsed follicular lymphoma, you have len rituximab on one hand and the various other options like obinutuzumab, bendamustine, PI3K inhibitors, BTK inhibitors. When compared to all these, it is clearly seen, considering the toxicity and the cost, len plus rituximab is one of the best options for follicular lymphoma relapsing after first-line R chemo, which is what most of us would use for follicular lymphoma at this point of time. OB plus bendamustine is having very good response rate, but most of the patients would have already received bendamustine in the first line, so this is not a good option. The PI3 inhibitors are very toxic, would reserve them for later use. BTK inhibitors have poor activity in relapsed follicular lymphoma, And whenever people have tried to combine all these regimens, Len plus R plus ibrutinib or Len plus R plus PI3 inhibitors, the rash and the unexpected DLTs are very high. So summary, this is my last slide. When to choose R square over R chemo in the frontline therapy of follicular lymphoma? Probably in patients who are unwilling for chemotherapy, when neutropenia is an issue. So especially when we are dealing with coronavirus and the COVID-19 pandemic, is Len-R a better choice compared to Len chemo because the neutropenia rates are much lower here? And also there are all these suggestions that Len might have a role to play in the COVID itself. However, what is direly needed is a biomarker for Lenalidomide response, which we do not have and been searching for a long time. What about the late effects? Are they worse with Lenalidomide? No. From the relevance trial, we can see that the second primary malignancy rates were similar. What about patients with grade 3A follicular lymphoma? Will the Lenalidomide still work? Fortunately, only 13% of the patients in relevance had grade 3A disease, and no subgroup analysis data was presented, so we do not know the answer to this question yet. What about MRD? What is the relevance? We need more long-term data. If you start with Len-R, what about second-line therapy? What about responses with R chemo? Again, the data on this is still awaited. In relapsed follicular lymphoma after BR, which to choose, R square or R chemo? Early relapse, definitely Len-R, that is R square. A trial of Len obinutuzumab versus chemo obinutuzumab versus adalimumab obinutuzumab is currently ongoing for relapse, that's early relapse follicular lymphoma. The results are awaited. For late relapse, practically anything would work. There is no direct head-to-head between R chemo versus R Len, but probably you can choose depending on the patient situation, just like you would take a choice in first-line therapy. We need to continue Lenaldomide beyond 6 months to 1 year. Again, data is awaited from the magnified trial. I will end here and thank you very much for patient listening.
Thank you so much, Prashant. That was fantastic. The second part of this use of Len in lymphoma will be covered by Dr. Gaurav Prakash. Gaurav Prakash is Additional Professor, Division of Hematology at Department of Internal Medicine, PG at Chandigarh. And he's going to tell us about Len in other lymphomas. Over to Gaurav.
Thank you very much, sir. And let me share my screen. All right. So after the discussion by Dr. Prashant on follicular lymphoma, my task is to discuss role of lenalidomide in other lymphomas. And so we all know that, lymphoma, majority of them are B-cell lymphoma, around 85% are of B-cell origin. And the common subtypes of lymphoma are usually aggressive in nature. Prashant discussed follicular lymphoma very nicely, but if we see in our Indian context, then you will find that in most Indian cities, follicular lymphoma comprises 15 to 20%. While in the Western populations, the data coming from the West, you will find the relative frequency of follicular lymphoma around 30 to 40%. So that leaves a significantly large part of lymphoma to be addressed with respect to lenalidomide. And because the 5 common and clinically frequently seen lymphoma are DLBCL, mantle cell lymphoma, marginal zone lymphoma, Hodgkin's lymphoma. Hodgkin's is a B-cell lymphoma, which is now clear, although we classify sometime it separately, but I would cover because this is an important lymphoma which we frequently see. Okay, so when we talk of Len in other B-cell lymphoma, then mostly you will find general impression if you talk to each other, your peers and teachers, you will find it is a drug to be used as a second-line, third-line agent in relapse refractory setting. Rarely ever you will hear somebody talking about, this is a patient of lymphoma, start lenalidomide the way you start in patient with 5q deletion MDS as discussed by Professor M.B. Agarwal. So we have to really see what is the current role and situation and position of Len use with respect to these lymphoma, aggressive as well as indolent. I will skip for the want of time. This has been very beautifully discussed. Cereblon is the target, but this is only the initial target. Ultimately, there is a complex downstream cascading effect of lenalidomide, which via these complex mechanisms leads to anti-tumor effect. Okay, so I will start where Dr. Prashant left. He discussed follicular lymphoma in the light of 2 beautiful studies, Augment and Magnify. I am going to take that further in context of marginal zone lymphoma. Relapse and refractory indolent lymphoma. The majority of the patient in this study were follicular lymphoma, but a very important yet small subset of patient was of marginal zone lymphoma that we will see. You have seen the protocol very clearly. 1 year of lenalidomide 20 mg plus rituximab. It was given, for 6 cycles. This was compared with placebo. Now, if you see here, majority of the patient, around 83, with follicular cell lymphoma, but now we have 17% patient, total 31, who had marginal zone lymphoma. And this is a point of interest for me for this presentation. And if we see the results with Len and Rituxi, you will find that in almost all subtypes, if you see from top, with prior rituximab, whether refractory, whether high tumor burden, chemo-resistant, unfit for chemotherapy, the Len was favored. But only in one subset, which is marginal zone lymphoma, it is almost at unity line, and there was no benefit of using Len in this study for relapse and refractory marginal zone lymphoma. However, we just saw, magnified trial, and it is, the results are still awaited, but I could get one abstract where some results are available. In this trial, the only difference from the augment trial was additional use of maintenance lenalidomide. There was double randomization initially in the induction phase and followed by maintenance phase, which, in one group they continued R2, which is Len with rituximab. In other group, they gave only standard rituximab maintenance. The results are here. I will focus on marginal zone lymphoma only over, and you will see that the median duration of response for marginal zone lymphoma was 35.8 months. It was not reached for follicular lymphoma, and we talk of progression-free survival. In fact, in marginal zone lymphoma, it was more than in patients seen with follicular lymphoma at 30 months versus 38 months. So we can probably conclude that R-square therapy is an active option, and it has a tolerable safety profile for patients with relapsed refractory follicular lymphoma as well as marginal zone lymphoma, although we have 2 trials which have conflicting results. And the second problem is, in both the trial, the relative proportion of patients with marginal zone lymphoma was less. Now coming to the talk of the town, everybody who is interested in lymphoma is talking of this trial, particularly follicular lymphoma or other indolent lymphoma, which is R-square. Now, R-square is so much appealing, and it is understandable. When you speak to a patient that you are not going to receive any chemotherapy, mostly you will be on oral treatment. The side effect profile is very much favorable, no hair loss, nothing of that kind, no oral ulcers. Few, things will happen which are very well manageable. It is so appealing. Let us see the data of R-square with MZL. Now, this is the BGH paper. Again, you will see, because marginal zone lymphoma is a rare lymphoma, so you will see less number of patients in any trial you see in context of this disease. In this trial, 30 patients which were newly diagnosed, all had stage 3 and 4, and they received again the standard dose of 20 mg, 15 to 20 is standard for lymphoma, with rituximab, and it was given for, again, same 21 days out of 28 days, 3 weeks out of 4 weeks, and it was continued for 6 to 12 cycles. There was no abrupt cutoff. Let us see the results. This is so remarkable. If you see, in patient with stage 3 and 4 marginal zone lymphoma, 70% had CR or CR unconfirmed, and the icing on the cake is 96% 5-year overall survival. Well, one can argue that in indolent lymphoma survival is high, but still with stage 3 and 4 lymphoma who were symptomatic, they have 96% overall survival with a chemotherapy-free protocol, and this is so remarkable. On the top of it, there was no treatment-related fatalities in this study population, although the number was small, but still the results are very remarkable. So with context of marginal zone lymphoma, we can safely conclude that R-square is clearly a very nice chemotherapy-free option for patient with newly diagnosed MZL. For relapsed refractory, we have conflicting data, although this remains an option in experienced hand in selected case-to-case basis selection of patients. Coming to a brother of marginal zone lymphoma, which is mantle cell lymphoma, again a post-germinal center lymphoma. And this was a landmark paper which came in 2015 in NEJM. I'm not going to discuss this paper. I'm going to discuss with you the 5-year follow-up of the same paper by the same group, which is the latest publication. And in this study, you will see that the therapy, the R-square therapy, Len with Rituxi, was given continuously for 3 years. This is the largest I have ever seen in any paper, where the lenalidomide was given for 3 years and rituximab frequency was reduced from once a month to once every alternate month. The patients on newly diagnosed lymphoma were slightly less, 36. All of them were 65 years or older. Now, in this also, the results were remarkable and very heartening for a disease as tough as mantle cell lymphoma. You will see that 23 CRs with a chemotherapy-free protocol out of 36 evaluable patients. However, the highlight of this study was MRD negativity. Now, MRD negativity was tested through a sequencing software, which is clonosec in this study, but this data is available only for 10 patients out of 36. And out of these 10 patients for whom we have clonosec data, 8, that is 80% had MRD negative CR, which is very remarkable result for a disease like mantle cell lymphoma. And if you see, this is not only initial response, this reflects in the survival. The OS and PFS at 3 years and 5 years is very healthy, more than 75% at 5 years for a disease like mantle cell lymphoma is very, very heartening to see. This is the graph of overall survival for patient on R square with mantle cell lymphoma. And we can conclude very safely, in relapsed refractory, there was no doubt. It was NCCN as well as US FDA approved drug already. Lenalidomide already was approved. This is the domain which is opening up a chemotherapy-free protocol, again with R square. The only caveat is that unlike marginal zone lymphoma, you have to give lenalidomide for a longer duration to have this kind of benefit in patients who are having mantle cell lymphoma. With this, I move on to the commonest lymphoma that we see in our daily practice, diffuse large B-cell lymphoma. Now, again, we have the same situation, a newly diagnosed patient of DLBCL or a relapsed refractory patient with DLBCL. Now, I start with a question, can we improve outcome of newly diagnosed DLBCL, focusing on activated B-cell because they are the bad guys, by adding lenalidomide to R-CHOP? The concept is simple because activated B-cell DLBCL, they are known to have hyperactive NF-kappa B pathway, and we know that Len interferes with that. So logically, this is a very sound concept, but let us see whether it translates into the good outcome or not in the subsequent slide. The robust trial is a trial I'm going to discuss. Very nice and simple design, R-CHOP 21 standard with R-CHOP along with Revlimid, which is also another name of lenalidomide. Now, this is a good study, good randomization, 570 patient, and you can see only the further randomization was done only in patients who have activated B-cell type. They received standard R-CHOP with Len, 15 mg was dose here because you were using complex chemotherapy, versus R-CHOP with placebo. This study was a negative study. Addition of Len did not improve outcome of activated B-cell type of DLBCL in a upfront setting. Rather, addition of Len was more toxic. You can see over here, more neutropenia, more anemia and thrombocytopenia than R-CHOP. Therefore, we can conclude, at least with this randomized phase 3 data, that upfront R2-CHOP is not better than R-CHOP alone. So coming to the other aspect, that can we improve outcome of relapsed refractory DLBCL patient after with using lenalidomide or as a combination or maybe a single agent therapy. Now, there are lot of data and, various kind of combination, various stages of DLBCL. Selected couple of, for the time constraint, for a couple of studies. And the latest study and very important study is, again, a chemotherapy-free, which is, I'm going to go, ibrutinib plus lenalidomide and rituximab. Now, in this, it is a costly regimen, but the beauty is it is oral regimen except rituximab, and there is no complex chemotherapy, conventional chemotherapy, I would like to say. Ibrutinib was used as a very high dose, 560 mg, rituximab standard, and Len, because in the phase 1b data, they used incremental dose of Len. Nobody was sure how lenalidomide is going to interplay with ibrutinib, so therefore they started incremental dosing to find the optimal dose. Rest other drugs were standard. Now see the patient population. You cannot find more difficult population of DLBCL to treat. Half of these patients had non-germinal center or activated B-cell type of DLBCL. 1/3 of them had transformed DLBCL. 60% were refractory DLBCL. Out of them, 27 patients were primary refractory, completely primary, did not respond to anything upfront. Now this is one of the most difficult subset in which this combination was tested. And the results are here. Around 1/4 Out of 45 patients, 11 patients achieved CR. 16% had stable disease, and rest of them had progressive disease. For some reasons, they could not give results, outcome of other patients because they were not evaluable. But still, with this kind of population, achievement of complete remission rate of 24%, or maybe overall response rate slightly higher, is an achievement. If you see that those patients who responded to this, they have deeper responses. Almost all waterfall plot, they are nearing 100%. So all those who responded who had CR, they had truly deeper CR, or should I say, almost complete regression of the pre-existing tumor mass. Can we conclude? Yes. The role we have is we need to still wait for some more time to see the role of Revlimid in upfront patient of DLBCL. However, in relapse refractory setting, various combinations were already there, and this kind of chemotherapy-free combination with ibrutinib is going to see used by us more often. Now, coming to the last part, which is classical Hodgkin's lymphoma. Traditionally, it is not a non-Hodgkin's lymphoma, but it is a part of B-cell lymphoma classification, so I'm going to touch upon it. There is a study of relapsed refractory classical Hodgkin's lymphoma. Those who deal with lymphoma, they know usually it is a success story, but the patient who had refractory Hodgkin's lymphoma are one of the toughest to be treated, almost on the line of multiple failure of DLBCL and mantle cell lymphoma. There are very few regimens which are effective in these patients. So in this subgroup of 33 relapsed refractory lymphoma patient, Hodgkin's lymphoma, 87% patients were previous BMT failure, and 55% of the patient did not respond to their past or the recent most therapy. Again, a very difficult population to treat. And in this patient, when the drug was given, so you can see CR rate of very, very ordinary 2.8%, almost negligible, only one complete remission, and partial response was also around 16. So less than 20% patient responded. And again, you can see this is very disheartening that in patient with classical Hodgkin's lymphoma, the responders were very few, and those who responded, the responses were not very deep. You can see, apart from the fact that the responses were not very deep, the responses were short-lived. This is a very, very difficult to see PFS survival graph for Hodgkin's lymphoma. And you are seeing from the very beginning, from the initial 2 or 3 months, there is a constant cascade of decline in progression-free survival. So in this setting, we can conclude that in classical Hodgkin's lymphoma, in relapsed refractory setting, we really need to wait for some more time to see efficacy of lenalidomide. As of today, it is not there. Now, the last point is we have seen the positive result of lenalidomide, and we are going to use it much more often in patient population who are having lymphoma. Now, we always talk of efficacy, but there is one difficulty with Revlimid, which led to the black box warning by the US FDA in patients with multiple myeloma, because there is a high risk of venous thromboembolism, and the rate of thromboembolism in patients with multiple myeloma is around 5 to 6%. Now, are we going to see similar kind of risk in patients who are having lymphoma? Let us see, this is data. This published in Blood Advances 2 years ago. And one interesting aspect they came out with is that there was a differential thrombosis risk in patients who were on single agent lenalidomide around 6%. But when lenalidomide was given in combination with biologics, like rituximab in our case, which is the commonest biologic we use, the risk of thrombosis was 2.9%. Now, this is a kind of slightly baffling that why, when we are using almost same dose in both the setting, why is it happening? So the author, as well as, I will agree with them, they provided 3 hypotheses for this observation. They said that if you use combination, there is a more rapid reduction of tumor burden. So the prothrombotic stage, because of presence of a tumor, reduces faster. Therefore, there is a less risk of thrombosis with len use. The second is a mechanical effect, because the response with a double agent or multi-agent chemotherapy with len is faster. Therefore, the mechanical compression is going to be lifted very soon. There will be less venous stasis. As a result, there will be less thrombosis. And lastly, there is a clear selection bias, which I am putting over here, because most studies which use single agent len, they selected patients who were of poorer general condition, of larger tumor burden, and who were not fit for combination. So these patients are more likely to develop thrombosis than patients who were much more fit. So this is also to be kept in mind. With this, I conclude my talk, And we can say very safely that Len has emerged as a very promising oral and affordable option for treatment of B-cell lymphoma, both upfront and in relapse refractory setting. In DLBCL, we know in various combination for relapse refractory cases, now coming in a chemotherapy-free combination, not yet useful upfront with R-CHOP chemotherapy. For mantle cell and marginal zone lymphoma, you can see we have a remarkable data for chemotherapy R-square protocol. I am sure we are going to see much more of it in the times to come, but we need longer treatment in patients who are having mantle cell lymphoma and clinical activity in selected situation in patients who are having relapsed refractory marginal zone lymphoma. For Hodgkin's lymphoma with Len, we have less data. Responses are less robust and responses are less short-lasting, and it remains one of the options at end of lines of therapy. You can always use it. Thank you very much.
Thank you, Gaurav. So that was a wonderful job done by the speakers, and we have now plenty of time left for the question answer, and we will take up the questions that have been put by the participants. Some of the questions are of general nature, so I will open them to all of you. So all of you can unmute yourself and all of you can participate. One of the questions that has been repeatedly asked by many participants is, in the COVID era, when you've got an immunomodulator drug like Len, is there any trial that is on about Len in COVID? Are there any results available? Will you use this as an immunomodulator? Will you use it with steroid, without steroid? So short or long answers by any one of you or all of you.
I think there are trials listed in clinicaltrials.gov. I just did a quick internet search when I saw those questions. I'm not aware of any results, but I think it's being tried. There are some trials which have been listed using low-dose lenalidomide in COVID patients. I guess we have to wait for the results. At this point of time, we do not know.
Right, so I think that was a very good reply. So please don't venture in your practice. Lot of quackery is going on in the treatment of this disease already. So let us not add at the moment anything to it, especially a drug like Lenalidomide. The another set of questions are regarding the dosing of Lenalidomide. All of us have talked about dose from 10 milligram to 15 milligram to 20 milligram to 25 milligram. So what decides all this? Is there authentic research available that in myeloma you'll use 25, in maintenance you'll use 10, lymphoma you use 20? Is there authentic research? On what basis this dosing has been decided? All of you.
To my understanding, sir, this is, I think, with the risk of cytopenia, I'm Gaurav. So, if you see in multiple myeloma, when Len came, it came as a single agent. Dr. Amit showed very nicely, then, or it came as a combination with dexamethasone. Now, we all know dexamethasone has virtually no myelotoxicity. In fact, it supports the bone marrow. So therefore, they use the maximum possible drug because Len was the main agent in study, 25 mg. But whenever it was tested for lymphoma, initially it was tested as a combination. So considering myelotoxicity of Len and anticipating profound neutropenia, most protocols started with a lower dose, maybe 10 mg, 15 mg. Now it is a personal choice between 10, 15 and 20 mg. Some people who are are more aggressive are treating patients with lymphoma who are more aggressive. In those trials, probably higher dose was picked up. Otherwise, people were more conservative whenever they use Len in combination with other chemotherapy regimen.
Thank you. Others want to chip in for this question? So I would like to just add something. There has been hot discussion on this subject in many meetings. And the most important thing is the efficacy. In different diseases, different doses in beautifully controlled trials have been shown to be needing a particular dose. For example, in lymphoma, 15 milligram versus 20 gram has already been tried and shown that 15 milligram is ineffective dose. So it is not empiric and it is not just related to the toxicity, the efficacy has to be shown. And in myeloma, from the same angle, a dose below 25 milligram is ineffective. Similarly, there are conditions where the Len had to be taken off the trials totally, and two conditions where Len was very enthusiastically tried and then totally withdrawn are chronic lymphocytic leukemia and Waldenstrom macroglobulinemia. It's extremely toxic to the marrow in these two disorders. So those who have asked this question whether this is empiric, I must say that there is nothing empiric. A lot of hard work has gone on in deciding what is the dose for which particular disease. So for maintenance, it is 10. For myeloma, it is 25. For lymphoma, it is 20. For MDS, it is low dose. And yes, of course, you individualize the dose. The biggest factor is the kidney. So sometimes you're extremely careful not to use it in kidney, and sometimes use it. You very carefully look at the myelotoxicity. The other question which relates, many people have asked, why do you give 3 week on, 1 week off? Anybody? Is it wash-off period? You are considering the toxicity to be reduced?
My understanding again, sir, is myelotoxicity. Continuously, lenalidomide is definitely myelotoxic over longer duration, especially the way we use in myeloma. So just to reduce the impact on bone marrow, we give a break of 1 week.
Others want
Gaurav on this. Yeah, I think because the primary toxicity is myelotoxicity, so that's why I think it has been designed that way to allow some level of dosing be continued.
Absolutely. Thalidomide is the only drug which can be continued through and through. Otherwise, whether it's pomalidomide, lenalidomide, they all require little washout period to prevent marrow toxicity. Otherwise, your counts can really drop. Patients can start needing transfusions, can get dangerous cytopenias. So 3 week on, 1 week off is almost uniform whether you are treating the disease or you are in the maintenance period. The other question that has been asked by various people is, which disease and in which phase you require aspirin, which disease and which phase you don't require aspirin? Anybody?
Len monotherapy, you don't require ecosprin, but if you are combining Len with dexamethasone, then the incidence of thromboembolism is high, so you add ecosprin with it.
So that's for myeloma, right? The questions are also for other diseases. Others would like to answer?
With the data I showed in the last few slides, where Len monotherapy was associated with more thrombosis, the risk was 6.4%. So if we go by that, probably the patient would need some kind of VTE prophylaxis, even with that dose. We still don't have a final answer to what will be the most appropriate DVT prophylaxis in this group. People have used low molecular weight heparin, warfarin, coumarin, as well as ecosprin. But the commonest and most easy to handle is ecosprin. We use ecosprin in our day-to-day practice in patients who are receiving lenalidomide. For lymphoma, after having seen today's data, I think probably even for single agent lenalidomide, I'm going to use ecosprin prophylaxis as a VT prevention strategy in these patients.
Any others? I mean, just add for MDS that in MDS it is not very popular, not required. It's not been recommended, and there is not great incidence of venous thrombosis despite these being elderly people. And one important reason is that some of these patients have significant thrombocytopenia as well. And you move beyond aspirin only if you are a prothrombotic disorder or you've had an episode of DVT. Then only usually you move to a higher drug like heparin or warfarin. The other question that has been put is because these drugs are teratogenic, can a male take this when he's planning pregnancy? When a couple is planning pregnancy, can the male continue to take it? Anybody?
No, the male also has to adapt to strict birth control practice with the use of contraception. And again, as I already mentioned, even sperm donation and everything is not recommended when patient is on Len therapy. It is teratogenic, even when the male is patient is taking Lenaldomide.
Right. So we discussed at length. Others want to chip in?
4 weeks gap is recommended between the therapy and the planning of pregnancy.
It's 4 weeks on either side. Be very careful. Last thing you want is to have a deformed baby. So don't take chances with any one of these drugs. Even if we do not have some great data in human on pomalidomide, but general application applies to all of them. There's some questions related to Len-induced second cancer. So is this carcinogenic drug, and can you really use it in maintenance for long period, is the theme of some of the questions. So others?
There is evidence for Len-induced secondary primary malignancy in myeloma, of course also with continuous Len therapy. So, but this benefit analysis showed that the PFS benefit is more than the secondary primary malignancy. But again, the patient should be counseled for continuous Len therapy and the risk of secondary primary malignancy. When on continuous,
absolutely, yes. Others?
As I showed, the data in lymphoma, at least in the randomized trial, the relevance trial clearly shows that there is no very significant excess secondary primary malignancy with lenalidomide as compared to chemotherapy. So, I mean, it's always been debated even in myeloma whether it's really an excess of second primary malignancy or just that those patients on the Len arm were living longer and that's why they were getting more malignancy. So, not very clear, but at least from the lymphoma data, it's quite reassuring that it's not higher than what you get with our chemo.
Right. Others? So, in short, you are not scared of this complication. It should be put to the patient before you are blamed because this has been widely discussed. It's always good. If somebody doesn't want it, it's fair enough. Otherwise, all the reasons that Dr. Ganeshan has put forward are the reasons why one is not too bothered about Len-induced malignancy. And most of the patients of myeloma where this has been discussed, they have received additional alkylating agents, they have received melphalan, their prior courses have been different, etc. We use thalidomide in thalassemia, and the question that has been asked is whether lenalidomide can be tried in thalassemia. Anybody? Okay, so I may just say that there is a experimental data on both Len and POM. Only experimental data, not in human beings. So long way to go before we have any data in human beings. So you and me should not attempt to do this in a benign disease like thalassemia. The other question is, it is immunomodulator. What about other immunological blood diseases? Is it useful in pure red cell aplasia, ITP, autoimmune hemolytic anemia? Anybody? Once again, absolutely there is no data, and I don't think primary immune-mediated hematological disorders, we use a drug like Len. Even a simple drug like Visolon, probably steroid, is probably more effective than Lenalidomide. So unless somebody produces some data, you will not venture into this. I have covered most of the relevant questions. There are some questions there which are a repeat of what has been discussed by the faculty. Probably it was not very clear or somebody didn't hear it. I may just, as we have time, I will put up some of those questions. One question to Dr. Prashant. Will you give it for a particular group of DLBCL as maintenance therapy?
So I think in DLBCL there is a randomized data.
And Prakash, both of you.
Oh, sorry. Okay.
No, both.
Yeah, I think Gaurav, you want to take it?
Gaurav, no problem. Gaurav, go ahead.
So in DLBCL there is a randomized trial which is compared lenalidomide maintenance after completion of R-CHOP. And that has shown improvement in progression-free survival, but no improvement in overall survival. But there was some suggestion that it benefits this elderly group of patients who have a high risk of relapse. So maybe you could consider in someone, if he relapses, there is no chance of salvaging or transplanting. So you want to give it for a particularly high risk of patient, maybe yes, from that data. But that's only one trial, and I don't think it's practiced as standard of care by anyone at this point.
Agreed. By and large, Len maintenance after DLBCL therapy, especially if it is a complete remission, is not a practice because the data to support the same is very scarce.
Okay, I may just say that recently we had a lymphoma webinar, and there the speaker from US was very enthusiastic about this indication. They said elderly people as such do not have many options. If they relapse, transplants are absolutely out. Even other drugs are toxic. So whatever additional progression-free survival has been shown, those who can tolerate Len, they have started using it left and right. So of course, this was one individual who said that she has been using it. There's no vast experience about it, but that was her view. There was a comment to Dr. Prashant that digital droplet PCR is not yet approved for diagnostic use. Prashant?
Absolutely. The data I showed was from a clinical trial, which is, I mentioned that is a provocative data. and it is very interesting. That's why I showed the data. I do not recommend that we start using digital droplet PCR for standard treatment at this point.
Thank you. There's another comment that the speakers should give the details whether a particular trial was phase 1, 2, or 3. So well taken. We'll try our best to put that kind of information when we quote some data. Sometimes because of the time factor and the number of slides you can have, you often miss this out. Another question is for Dr. Amit. What's the duration of Len in myeloma?
Now the recent database has already shown that continuous Len therapy is recommended. So there is until the disease progression, toxicity, or the patient withdraws from the Len therapy.
Others want to add? What you do in your practice? Duration of Len?
Only for 2 years.
Okay, so it's a question which is trying to be answered in the endurance trial, part of which was presented by Shaji in ESCO and EHA this year. What he presented was that carfilzomib with lenalidomide and dexa is not superior to bortezomib in the part of endurance trial, which has gone on for 10 years. The part 2 of that study is whether Len is required for 2 years or longer is beneficial. That data was not presented. So we don't have an authentic answer to this question, whether it will be toxic or more effective. We have to wait for that study. There is no other study ongoing in this particular aspect. Another question is, what is the dose and duration of erythropoietin stimulating agents in MDS? So Dr. Abdullah, erythropoietin stimulating agents, whether it is erythropoietin or darbepoietin, is usually continued until the efficacy is lost. The median duration of efficacy is about 2 years. There are patients where they have done wonderfully well even for years, 5 years, 7 years, and 10 years. I have one of my own professor who is now in 80s, and last 10 years he has been on erythropoietin. We've reduced the dose to half. We've increased the interval to double. Of course, hemoglobin a little bit drops, but is maintaining more than 10. So in most of these conditions which are not curable, the drug is continued. This is a very sweeping statement I'm making. The drug is continued unless there is a serious toxicity or the efficacy is lost. And same applies to ESA, Darbe, or erythropoietin here. What is the mechanism of secondary leukemia in patients who get Len? Anyone wants to talk about that? Mechanism of second cancer. Same it comes to, is it carcinogenic, I suppose. None of us are basic scientists, but if somebody wants to answer this question, go ahead.
So there is actually a beautiful review article which has looked into the secondary malignancies, especially in multiple myeloma. And the authors there concluded they're not able to come to a definite conclusion. So as previously discussed, it was thought to be because of if these patients are surviving for longer period of time, or because of the concomitant drug, for example, other drugs that are used for the same condition, or because of age, as it is because at high risk of secondary malignancies. So the effect of lenalidomide, it acts as an immunomodulatory agent. It increases the anti-tumoricidal immunity. Why it can lead to secondary malignancy is actually not very well known to this day.
Right. So I'm going to guess that immunomodulators are dangerous drugs. When you play with body immunity, you invite problems. So one has to be a little careful. That's all I can say. In practice, we do not consider this as a big issue. So when you're talking to the patient, your counseling should be a bit positive, because patients in India at least will do what you say. So if you say that this is going to create cancer, they'll not take it. You say clinically safe, he's going to take it. So you should decide for the patient. Other question, which is, I think the answer exists, is does Len interfere with stem cell harvesting in myeloma, Amit?
Yeah, the number of stem cell dose they have shown to be a little bit decreased after 5 to 6 cycles. So after 3 to 4 cycles, we should go for stem cell harvesting, but not a big issue. With the help of Larixafir and cyclophosphamide-based harvesting, which is done, that's not a big issue right now with Len.
Others? So, okay, 4 cycles are very easily given and it does not interfere. But if somebody is not interested in transplant immediately, you should harvest the stem cell and keep it, because otherwise you may require maneuvering to obtain the stem cell. What is the dose and duration in myelodysplastic syndrome? So I think answer is same. You continue it till the efficacy is lost, so there is some serious side effect. Median duration of response is 2.5 years. When it starts failing, we often, before stopping it, add erythropoietin or Darbe and see whether the combination is working. Will the use of steroid with Len affect its immunomodulatory action? Is the question. So maybe Amit, myeloma, you
yes, Len with dexamethasone augments the immunomodulation activity of Len. So that's why we are using it is synergistic action of dexamethasone. So with Len, that's why definitely it augments it.
So it augments, it does not interfere. In other conditions, does it do that? Lymphomas and all? Does it interfere with the efficacy?
Nobody has tested that from that angle, but if I can recollect, it has been used with a steroid in R2-CHOP or RR-CHOP, in which there was no drop in efficacy, but this is just a derived opinion.
So that completes all the questions. We have a couple of minutes. I must say that this was a wonderful experience of discussing one single drug, which is so versatile, useful in so many conditions in varied ways: efficacy, maintenance, toxicity, dosage, mechanism of action, multiple methodology by which it works. The drug is wonderful, and it has survived for 2 decades. That itself tells you how versatile the drug is. So it's over from my side. I hand over the dais to the sponsors. Ashutosh, it's all yours now.
Thank you, sir. A big thanks to elite speakers for their wonderful talk on Lenalidomide, a versatile immunomodulator. I'm sure all participants have felt today's discussion insightful, interesting, enlightening, and much more. I'm thankful to Mice Ideas for flawless execution of the program. Last but not the least, I am thankful to Team Adley for follow-ups with all India doctors. I have a couple of announcements to make. The first announcement is we'll be emailing the newsletter of today's webinar to all the participants as well as to the doctors who have not able to attend today's meeting. So that will be done in next 3-4 days time. That is first announcement. And the second announcement is like that, as you all are aware, that because of COVID, the entire world is into the back foot. And many millions of people, they have lost their jobs and business. So in case if you come across any unaffordable patient, we at Team Adley will ensure that we will support the patient with free of cost drug. And this support will be absolutely unrestricted. Thank you so very much.
Highly appreciable.
Thank you, Ashutosh. Please don't log out. Please don't log out. All of you are there?
Yes, sir.
Yeah.
We do have some more questions, and as we have time, I think it's our duty to answer them. There is a question about lymphoma for relapsed ABC subtype of DLBCL. What is your comment about using Len with ibrutinib and rituximab?
So actually, the study I discussed was exactly the same. 51% of the patient in that study were ABC DLBCL who were chemorefractory also. And the result that study this combination showed is around 24% complete remission rate. This is definitely going to be the future of DLBCL, especially the activated B cell type in the times to come. The only hindrance in that is the cost. Once ibrutinib is more easily accessible and affordable, should I say, then this combination, particularly with this cohort, is very important. However, if we go with the ibrutinib combination upfront in the Phoenix trial for DLBCL, it showed benefit only in one cohort. So upfront, still we are not clear whether ibrutinib or Revlimid adding to our job going to change. But in relapsed refractory setting, this is going to be the future. This is my personal feeling.
Thank you so much. Anybody wants to add? Prashant, Ganesh? Okay.
I think that's fine. I think whatever
Sure.
said, I agree with it.
So if some of you had attended our symposia webinar on DLBCL, we presented the data of MD Anderson about Smart Start study, which was nothing but rituximab, len, ibrutinib to start with, and then get on to the RCHOP or DAR-EPOC protocol. And fascinating one-center results have been produced with markedly reduced morbidity mortality of the treatment. So that is another area. And of course, for people who are not fit for chemo, those who have relapsed, this is an important step. Remember that you need to prove ABC subtype. That's very, very important. The question related to myeloma, if Amit is around, do you have to replace len with cyclophosphamide if the creatinine clearance is low, or you can use low-dose lenalidomide?
Basically, we have got len dose adjustment, but it's better to replace len with cyclophosphamide at the initial presentation of the patient coming with a myeloma kidney disease or a bortezomib-based containing regimen we can use. So bote is safe, cyclophosphamide is safe, but len would be difficult initially if the patient has got myeloma kidney.
Right. And Gaurav, there is a question for you. In mantle cell lymphoma, when will you prefer R square versus R chop, R DHAP?
Upfront, this is a very difficult question to answer because maximum existing data is with combination chemotherapy, immunotherapy, R-CHOP, RDHAP combination, alternating cycle or sequentially. Because still, in India, if you see experience, we see much younger patient and the attempt is always on the cure. So if a patient is fit and if we take away this pandemic of COVID, then, giving combination chemotherapy with immunotherapy is the way to go. However, if I bring in the latest data, which is coming with R square, as well as we bring in the risk of more cytotoxic chemotherapy in the light of COVID, then starting R square chemotherapy in these circumstances and observe it is going to be a very good idea.
Thank you, Gaurav. And my last part is to narrate out the names of the participants who have put the questions. We have 440 participants at this stage. 56 of these are from out of India. Questions were put by Dr. K.K. Gupta, Dr. Prem Raj Srishtha, Dr. Paresh Dave, Dr. Parathan Kurunakaran, Dr. Moyuddin Khan, Dr. Pradeep Sirivardena, Dr. Abdullah Mosabir, Dr. Naresh Taide, Dr. Amol Kotalwar, Dr. Pankaj M. Shah, Dr. Akshay Lahoti, Dr. Amar Ranjan Singh, Dr. K.K. Gupta, Dr. Ramawat Arjun Kumar, Dr. Thanuja Disanayake from Sri Lanka, Dr. Krishna Ratnam, Dr. Kendam Sanath, Dr. Gopinathan, Dr. Haritha from Colombo, Sri Lanka, Dr. Karuna Kumar, and Dr. Krishna Ratnam. So, well, thank you very much, and that brings us to an end. Thank you very much, and have a wonderful lunch at your home. And maybe some of you will see in the evening at 6:30 for the CML with Dr. Ilyas Jabwar. Thank you.